lives are affected daily by chronic wounds. Throughout the month of June, the ABWM Foundation will bring awareness to the work of wound care specialists on wound healing and provide useful educational resources. In addition to Wound Healing Awareness Month, the ABWM Foundation designated June 10th to June 14th, 2024 as Certified Wound Care Specialist Week. This week celebrates all practitioners certified by American Board of Wound Management, which includes the Certified Wound Care Associates, Certified Wound Specialists, and Certified Wound Specialist Physicians. As you work with older adults across care settings or at home, you have likely seen the impact of wounds that won't heal. While about 2% of the general population has chronic non-healing wounds, nearly 15%, which is 8.2 million, of Medicare beneficiaries have at least one type of wound or wound-related infection. The American Board of Wound Management, which is the ABWM Foundation, has named June as Wound Healing Awareness Month to help bring attention to the challenges of chronic wounds and provide more information about addressing those challenges, including the importance of nutrition. Wounds develop in a number of ways, including from surgery, trauma, or pressure injuries. Chronic non-healing wounds do not respond to initial treatment and do not heal in the expected time frame, which is usually within 30 days. In the US, chronic non-healing wounds cost Medicare 2.81 to 96.8 billion annually. Open unhealed wounds raise the risk of infection. Unhealed wounds raise the risk of infection and additional complications, including loss of limbs, increased cost of care and mortality, and decreased quality of life. Who is the highest risk? Chronic non-healing wounds typically occur in individuals with more complex medical needs and those with multiple comorbidities, particularly diabetes and obesity. Older adults are also at increased risk. Among Medicare beneficiaries, the highest costs for chronic non-healing wounds are for those related to surgical wounds and diabetic foot ulcers. Wounds can stall in the healing process for many reasons, including restricted blood flow, immunosuppressive drugs, poor mobility, and poor nutrition. While some of these risk factors may be difficult to overcome, poor nutrition can be improved. That is a little bit of the information about the what we will be dealing with today with the WHAM, and we want to allow Dr. Mitchell, who will be our speaker for today, to come and give us more information on wound healing. But before she does that, I just want to say a few words to introduce her. Dr. Monique Mitchell is a proud alumnus of the R.M. Bailey High School and the University of the Bahamas. She holds a Bachelor of Science in Nursing with a minor in Community Health and a Master's in Public Health in Health Promotion and Education. She returned to university and obtained a Doctor of Podiatric Medicine from the Barry University and completed residency at the Mount Sinai Medical Center in Miami Beach, Florida. She is a board-certified wound specialist physician and a diplomat in the American Board of Multiple Specialties in Podiatry in the prevention and treatment of diabetic wounds and diabetic footwear. She is passionate about lower extremity amputation prevention, preserving the diabetic feet for life. She is a member of the Caribbean Regional D-Foot International, American Limb Preservation Society, Save a Leg, Save a Life Foundation, and other worldwide organizations concerned with ending avoidable lower limb amputations due to diabetes. She is a trainer and a facilitator on diabetic foot and wound care for laypersons and health professionals. She has been employed with the Ministry of Health and Wellness for the past 35 years in various capacities and is now in private practice as a podiatrist at Family Foot Center in New Providence and Grand Bahama. So we would like to welcome Dr. Mitchell today as she presents on lower extremity wounds. While her presentation is happening, you can definitely jot down your questions. And at the end of her presentation, you will be able to open your mics one by one to ask your questions at that time. So let's welcome Dr. Monique Mitchell. Please give her your undivided attention.
Good afternoon, everyone. I'm very excited to be here to be doing this presentation. Give me 1 second, let me close my door. And so hopefully we will, like a nurse said, we will learn some stuff today. So we're looking forward to that. Let's get started because our time is short. And I want to say welcome to everyone. I see Dr. Bell is on and Ms. Brown is on. So we're very looking forward to your presentations as well. Thank you so much. Let's get started. So the lower extremity is, of course, anywhere from below the knee. The scope of practice for podiatrists is from the tibial tuberosity. And if you feel below your knee, there's in the front side, there's a bone, kind of triangular shaped bone there. That is the tibial tuberosity. And so from there down is the lower extremity. So we can talk about wounds anywhere there. Okay, so we have short objectives today. I'm gonna ask the nurse to just keep an eye on the waiting room because I see some persons are in there, but I'm not gonna be able to let them in. So if you can let them in, please. Okay, so we're gonna distinguish between the types of lower extremity wounds, review the pathophysiology or the etiology of these wounds, describe the basic principles for wound care, and then we're also gonna look at some strategies for looking at those specific types of wounds. So nurse also talked about acute and chronic wounds. So I really won't cover this again, but we took it mostly when we're talking about lower extremity wounds, we're talking more about chronic wounds that have stalled or are taking a while to heal. And so those are more what we'll be talking about. Acute wounds are more maybe surgical or maybe traumatic or something like that.
Let me give you your number.
All right.
42.
Can we mute Noreen, I believe it was. Okay, so these are there are many types of wounds all over the body, but in the lower extremity, these are the most common ones that we will be covering. And of course, the arterial, venous, and diabetic are more common than the pressure ulcers, but I will also cover pressure ulcers a little bit today because that's also a common area, especially in persons who are bedridden and persons who may be in a wheelchair or something like that. And so, and then we have a lot of nurses who also care for persons like that. So I'm not going to cover the statistics too much because the nurse Monique already covered most of that. But 13% of the US population has a low extremity wound at some time in their lifetime. And then the healthcare system spends more than $20 billion on lower extremity wounds. 2.5 million Americans develop a venous ulcer. That's just a venous ulcer every year. And about 25% of diabetics will get an ulcer at some time in their lifetime. So we're talking about a lot of persons, and that's just most of that was America. But when you think of the whole world, sadly, we don't have good statistics here in the Bahamas yet. But definitely we can see that it will be very similar to those numbers in terms of the percentages.
the customer service and the site visits. So,
So pressure ulcers are, of course, wounds that occur that damage the underlying skin and underlying tissues because of pressure or constant pressure on the wound or on the lower extremity. Most often in the lower extremity, it's going to be in the heel. So that's why you see that picture there. So what actually occurs is that there's three types of pressure, I guess, or forces that lead to these pressure ulcers. And it can be pressure, shear, or friction. And the difference are here. So pressure is just the weight of the body pressing down on the skin. And usually it's under a bony prominence. And that's where you will see the pressure ulcer occurring. The layers of the skin are forced to slide over each other. And if you remember our nursing days, when you pull a patient up in the bed with the draw sheet or without a draw sheet, then this is would be with a classic case of shear forces. And then friction, of course, is constant rubbing of the skin, and that can actually lead to a wound. And the risk factors are, of course, age. Persons who are older are at higher risk for developing these types of ulcers. Immobility, if they're paralyzed or they're bedridden, then that is something that increases their risk. Nutrition, if they're challenged, and then, of course, if they have other medical conditions. So what are the characteristics of pressure ulcers? So we have some examples here on the side. They're usually over bony prominences and areas of the body with little fat. And as persons get older, they tend to lose weight. And so you can see more bony prominences at the hip and the heel, the ankles, the medial and lateral malleolus tend to be areas as well where they would get pressure. So of course, most common sites are the hips, buttocks, heels, shoulder blades. But of course, for us, it's the most often the heels, and then followed by the medial and lateral malleoli. And then this is also based on the level of skin damage. So here is the NP, UAP pressure ulcer staging. And so this is very common to most of us as nurses and physicians. This is something that we use to identify what type of wound it is or what level of the injury is. So you can review that as well. And then so prevention, of course, we can use the Braden scale to identify persons who are at risk for developing pressure ulcers, keeping the skin clean and dry, making sure that there's local wound care. If there's, like, for example, a stage 1, you would take care of that to prevent it from going to a stage 2. Repositioning every 2 hours to relieve the pressure. And then you can also use devices to help with the pressure relief, such as the mattress or pressure relief mattress or pillows, or examples here are some examples for the heel. You can use those as well. And so they can definitely help with preventing these pressure ulcers. And I think the medical supply companies here have all of these devices in their stores or something similar that would be able to use. So this is a patient of mine who had a pressure ulcer. And so you can see they did go on to heal. And so you can see that they started here and then we moved on. And a big part of that process was to provide relief to their pressure on that area, whether that's putting a pillow under the heel or having one of those devices. So you can also use a pillow if you don't have all of these new devices. Okay, so we're moving on now to arterial ulcers. And of course, we know that this has to do with the blood flow, because the arteries are the vessels that take the blood to the different parts of the body, including the feet, which is, of course, the furthest from the heart. And so it can also be a result of some trauma that can have kind of damaged the blood vessels. But most often, it's chronic progressive arteriosclerosis, peripheral arterial disease, arterial embolization, and of course, ischemia. So these ulcers develop because there is not enough blood flow to the lower extremity, and then resulting in a non-healing ulcer or even gangrene. So you can see these pictures here on the left-hand side. We can see there's a gangrene and then also to the dorsum of the hallux there on both of them. And this one also has a fourth toe involved. So the location of these wounds is usually on the top or between the tips of the toes, over the phalanges or the toes themselves, the head of them, and around the lateral malleoli, or the anterior tibia. So that's the lower leg and the feet. So they're very painful. So I want you to take, if you're taking notes, we will make the PowerPoints available for you as well. And then it is being recorded, so you can also watch it or share it as well. So these types of ulcers are very painful. They're sharply demarcated, so you can look on it and you can see clearly where the ulcer is. The color is usually pale to yellow base and then minimal drainage. It can be dusky or grayish looking or cyanotic, a little bluish looking, and then gangrene can be present. And then we classify them as either chronic limb-threatening ischemia or critical limb ischemia as well. So what is the focus of our treatment for arterial ulcers? Well, initially, when that person comes in, they need to have vascular studies as the most important thing. So we will know exactly if this ulcer is going to be healable or if they're going to need revascularization. So the first thing is you can do like a smart ABI, or you can do a manual ABI. Whatever you have within your environment, you would do that to be able to assess this person's blood flow. Of course, we know that feeling the pulse is not enough to be able to determine this. So we need to have a vascular testing. And if you don't have access to vascular testing right then that patient should be referred to someone else who can do the vascular testing before you do anything else on this patient. So if the ulcer is found to be healable, meaning that the person has blood flow, significant blood flow to the lower extremity, then you can start your treatment. Of course, you can use medications such as aspirin or Plavix or cilostazol or something like that to increase or help to increase the blood flow. Smoking cessation, person should be consulted to let them know that they should not be smoking, because that is decreasing blood flow to the area and can definitely impair healing. You can also use adjunctive therapy such as infrared light therapy that can also help with the healing. If we'll talk about generally about the moist wound healing and all that at the end. So for treatment, if that person's vascular status is either not determined or it is not good, meaning that the ABI was not at a level where we feel the wound would heal, or that they don't have good blood flow, the feet may be cold, they may be cyanotic, they may have gangrene, then you know that person's need to be seen by the vascular surgeon. So know if your determination is that wound may not be healable, then you keep the wound dry and then keep it stable, and then you refer them to the vascular specialist. Do not debride the wound. Do not put any Silvadene on the wound. Do not put betadine on the wound. Bactroban on the wound. You can put betadine on it, and you can also put a wet to dry betadine dressing. You can put an alcohol wet to dry dressing on it, and then you send them off to see Dr. Sands, Dr. Lucas, Dr. Farquharson, or someone like that. Because at the end of the day, they may need to have revascularization or even a partial amputation to be able to salvage the leg. So I want to just repeat, do not put any creams on the foot. No cream, no cream, no cream, and do not debride the wound. Just send them off to the vascular doctor. And this, I like this here, no blood, no healing. So if you don't take anything else from this slide or this section, just get that and know not to put any cream on it. So these are some examples of gangrene to the hallux, as well as this one here to the hallux and the second toe. This person here already had looks like above knee or below knee amputation as a result of the ischemic wounds. So we don't want to contribute to that or delay treatment. So as fast as you can refer the patient to vascular, the better it is for them. So we're moving on now to venous ulcers. So venous ulcers are actually the most common type of lower extremity ulcers, and they develop because of weak or damaged valves in the veins in the legs, so that they are unable to pump the blood back up to the body. And this is, of course, venous insufficiency that results in the incompetent valves that can lead to venous hypertension, and then leads to the edema, and then leads to the ulcer or changes in the skin, and then eventually the ulcer may develop. Some of the risk factors for this are a history of DVT or failed calf muscle pump, obesity, age and increasing in age, and then of course pregnancy. The more children the person has, then a lot of times they have a higher risk of these venous ulcers as well. So now we're looking at where these venous ulcers occur. So the medial and lateral malleoli area is the most common location, and this is usually called the gator area. So if you look on this picture right here, you can see here, this is the medial leg. You see, this is the big toe. So this is the medial side of the leg, right above the ankle, and that is called the gator, medial gator area. So superficial, these ulcers are usually superficial. They can be deep as well if they've been there for a while, but they're usually superficial with irregular margins. Like we saw in the arterial ulcers, they were very, very demarcated, so you could see exactly where the margins are. But sometimes with venous ulcers, it's kind of irregular. The color is usually red, beefy red, granular base, with moderate to heavy exudate. And then the surrounding tissue could be reddish, brownish, sometimes black in our population. A lot of times you'll see, but it's definitely hyperpigmented. And if they had previously had a healed ulcer in that location, sometimes it could be hypo or lighter in that area as well. You may see like a little clearing in one area, and then around it, you see the dark spot around the area. So you may also see other skin changes like dermatitis, dry, scaly area around where the ulcer is or around where the ulcer may have been. And this looks like an inverted champagne bottle. So that just means that the top of like where the calf is bigger, and then it tapers down to where the ankle is. And so that's what we mean by a inverted. If you turn a champagne bottle or a wine bottle upside down, the top part will be wider, and then it'll come down to the narrower toward the ankle. And then pain is common, but it can also be painless. So sometimes but I find most often persons will have some tenderness, especially if they're sitting and having the foot hang down. They will tend to have some pain with venous ulcers as well. So that's another picture, and that shows the inverted champagne bottle kind of a little bit better than this one. So you can see that as well. So this is the classification for venous ulcers. We won't go through all of them, but it's a spectrum. So you don't think it's just when the person gets to the ulcer that they have this venous disease. It can start anywhere from no visible changes. Then they have the small, tiny veins and telangiectasias, and then the big tortuous veins, the swelling. Then now you begin to see the changes in the skin color. Then they may have had a previous ulcer that healed, and then they have an active ulcer. And so we need to, I put this here just to remind us that it's a spectrum. It's not just when the person has that active ulcer. And then we need to remind persons that once the wound heals, we still need to treat the venous disease by compression or whatever else we're going to do. So that's the purpose for that. So the goal for treatment here is to heal the wound by helping to increase the venous return, and that means to push that blood out of the lower leg back into the circulation so that it could be circulated by the heart again. Because the longer that blood stays in the lower leg, meaning if the leg is hanging down or they're standing for long periods or sitting with the leg hanging, that can increase the edema and increase the wounds as well. So we want to decrease that as much as possible. Decrease the venous hypertension, decrease the edema, and increase the venous return. So compression bandage, of course, is the gold standard. And then that is used. We have one example here is the Coban 2 or Pro4 is very common here as well. We use that a lot. So compression bandages are applied weekly. If you probably just started, you may do it probably 2 to 3 days or to see how the person tolerates it. But generally, they change weekly so that the person can benefit from the compression. So graduated compression hoses are used once the wound has healed so that you can prevent recurrence. Proper skin and wound management. You can use topical antibiotics or other topical treatments that you may need during the healing process. And then, of course, a lot of persons are on either Daflon twice a day or 1,000 milligrams once per day to help with the management of it. So compression therapy, again, is the gold standard. Elevation is also very, very important. The pneumatic compression device, which is a pump that helps to pump that fluid out of the leg, is also available. That persons can use Pro4 bandages, provides 40 millimeters of mercury at the ankle. And then we can also use a non-stick stretch bandage such as Unaboot that can also help. Sometimes when the wound is weeping a lot, the Unaboot tends to work a lot as well. So once that wound is healed, then that person needs to be in compression stockings or hoses for the most part. They're going to have to wear at least probably a class 2 to 3 for them to be able to prevent that ulcer from reoccurring. And then there are a lot of devices on the market that help persons to actually put on their stockings. So we didn't cover that a little bit, but there are a lot of devices that can help because that, of course, is the #1 complaint for persons patients. They can't get their stockings on. So, but we can definitely help with that. Okay. So for venous disease, also, we want to encourage persons to improve their lifestyle as well. Regular exercise or moving. It's important to get that blood flowing, engaging the calf muscles. That can be by squatting or walking to make sure that that blood is flowing. Maintaining a healthy weight. This is more common in persons who are obese or heavier. So quit smoking, of course. Everyone should do that. Wear compression garments as far as possible. Avoid long standing or sitting, and then elevate the legs when they're reclining. So those are important. So here are some examples of venous ulcers that I've seen in my practice. And so we could see that various stages. So for example, this one here, we could see that this is what I was talking about when you see the pale area. So all of this was a wound. And this part, all of this part here is healed. And so this is just the remaining part of the wound. And then this here is the color of the skin. So you can see how dark that is. But this part here is kind of clear, kind of whitish because they have lost the pigmentation during the healing process. So, okay, so here are some additional venous ulcers. Again, we see the hypopigmentation or the clearing hair, and then we see the darker skin around the edges. And then this here is a good example of the champagne bottle type ankle or type leg, where it's really big up to the top here, and then very narrow or narrower down at the ankle. So that is what they mean by the champagne bottle. So now we're going to move on to diabetic foot ulcers. And this is one that is really dear to me. So I love this one. So diabetic foot ulcers, are there any questions so far? You can just put them in the chat, or we'll give you an opportunity to ask them at the end. I know I'm going a little fast, so we're going to provide you with the PowerPoint as well. And then also, if you have questions, you can also send them in as well. So diabetic foot ulcers, persons who are at risk, the risk increases the longer years that they've had diabetes. Having a previous amputation, of course, increases the risk of getting an amputation. Having a previous ulcer also increases the risk of another ulcer. Presence of callus, especially, we'll talk a little bit about the type of callus. And then the foot deformity, whenever you have a hammer toe or a bunion or some bony deformity on the foot, it definitely increases the risk of getting an ulcer. Limited joint mobility, especially in that big toe. If persons are unable to move that big toe up, a lot of times they will get an ulcer underneath the first metatarsal or the big toe area. If they have visual impairment or mobility problems, that also increases their risk. And this basically, I think, speaks to how advanced the disease is, and that's the reason why they have increased risk. And then age, of course, the older the persons are, that correlates with the years of diabetes, and then, of course, the male gender. And there are a number of factors why men tend to have poorer outcome with the ulcers generally, and then, of course, with diabetic ulcers as well. One of them is that they tend to take longer than women to come to the doctor to get help. And so that's one of the reasons. So the mechanism of injury or the etiology for these ulcers can be low pressure, the development that's prolonged constant pressure. For example, if you're wearing a shoe that doesn't fit properly and you continue to walk in it, because I guess most persons here would say, why would they continue to walk in that shoe when it doesn't fit properly or it's causing trauma? Why would diabetics do that? Why would, can somebody open their mic and tell me that, please? Why would persons with diabetes continue to do that? I'm gonna give you a minute to open your mic and tell me why persons would continue to wear those ill-fitting shoes if they're diabetic. Why do you think that?
They can't feel very well.
Exactly. And what is that condition when they can't feel?
Neuropathic.
Yes. Awesome. Yes. They have, most likely, they have some degree of neuropathy or loss of sensation or feeling in the feet. And so while they're wearing that shoe or they're wearing that sandal or whatever they're wearing, they're not feeling any pain. And so that's the reason why they can continue to have that prolonged constant pressure on their feet. That is enough to actually cause probably a blister, a callus, and then a wound. So sometimes you can also have repetitive moderate pressure, and this is the shear forces on weight-bearing areas over bony prominences. So when I think of this, I think of somebody who has a Charcot foot maybe, and they have that bony prominence at the bottom of the foot, and they are constantly walking. As they're walking, they're rubbing, that area is being rubbed, and then eventually they will get an ulcer in that area. And I didn't put a picture. I'll put one in before I send it out. And then you can, of course, have high pressures, and this could be from puncture wounds to the foot, and that could be trauma. Maybe they step on something, a nail, a tack, something like that. That can cause direct pressure into the foot. And so those are all the ways that these injuries can occur. So neuropathic ulcers are generally painless because we said that they're neuropathic, and a great percentage of neuropathic ulcers are also ischemic. So that means that they don't have good blood flow to it, but there are some that do have good blood flow to the area. So generally they're painless because the person is neuropathic, so they don't feel that ulcer or that sore there. And then the patient is usually unaware of the lesion, and they would usually notice either blood or pus on the sock or on the floor, or somebody else tells them, or they may even smell it before they actually feel it. So there's a lot of times persons will come and say they don't know how long they've had the ulcer because they just didn't check their feet. So the location is usually over a bony prominence, usually on the plantar aspect of the foot or the bottom of the foot. On the bottom part of the foot, remember we talked about the arterial ulcers, they were more on the top of the foot. But the diabetic ones are more on the bottom of the foot. And can be at the toes, can be at the midfoot, can be anywhere along the bottom of the foot. So this here is a nice example as well of this punch out, that heavy callus around the ulcer itself. And this is sitting right here at the second metatarsal. So right under that bone, that's where that ulcer is sitting. And so that is classic for a diabetic foot ulcer or a neuropathic ulcer. So the most common location is the plantar first metatarsal. Remember, I mentioned that if the person had limited mobility or limited motion in that first metatarsal joint, if they don't have a lot of motion in there, every time they stand or walk, they will have friction that's pressing on that metatarsal head. And eventually it's going to rub, and that is going to cause callus, and then it's going to cause an ulcer. I think I have a picture in here so you can see as well. So the great toe, weight-bearing surface of the foot are also common. So anywhere there, this is an example here, and this is also another example. So when I talked about callus, let me see if I have. So this callus here, you can see the difference between the callus here on this picture here, where it's clear and it's probably a little yellowish, but it definitely does not have any red or blue or brown colors in them. So when we go back now to this callus, we can see that this has red and probably dark blue and more colors within the callus. And usually if you see that, that is a sign that you need to move and do something, because that is called a hemorrhagic callus or a bleeding under the callus. And that usually indicates that there's a wound or an ulcer under that callus. And so once that is debrided, then you imagine that it'll have something like this underneath it. So whenever you look at your diabetic patient and you see that they have this type of callus, that is time to do something. You have to get them to see the podiatrist or to see their primary doctor, because that callus needs to be debrided, so that taken off, so that they do not, so that we can treat that ulcer. The foot is usually warm and pink, can be dry. Pulses are usually palpable, but like I say, sometimes you do have ischemia along with these neuropathic ulcers. So sometimes the blood flow is not always good. So here are some other examples of neuropathic ulcers. This is in the midfoot, the middle of the foot. This person had Charcot foot, and this ulcer here was there constantly because of that bony prominence pressing down underneath the foot. This, of course, is the tip of the toe. If you look at the top of it, it'll be a hammer toe on the top of there, pressing that toe down so that the person is getting a lot of pressure. And then, of course, this is the first metatarsal, like we talked about, as it relates to no range of motion or little range of motion. This is common when you see persons have bunions or as well. So here are some other additional examples. This is a patient, this is a fourth toe, and they have a hammer toe at that area. Yes, they had amputations previously, and that as well has contributed to that. And then this is a midfoot here. You can see these are the toes here, and this is the heel. And this here is an diabetic ulcer as well. This is a big toe, the hallux, and it's this person has hallux malleus, or the toe is a little fixed in that position. And then this ulcer right here is at the tip of that toe. And so we could see that definitely because of pressure, they develop these ulcers. So the treatment goals for diabetic foot ulcer, of course, is to relieve that pressure called offloading. So there are many, many, many ways that we can offload. And based on your area of practice or where you are and what your scope is, you can use maybe all or some of these methods as well. So I put a lot here. So bed rest, of course, is the easiest, non-weight bearing. Just get off the foot. Sit down, lay down, just get off the foot. And that alone will help that ulcer to heal and the person to do better. Debridement or shaving the callus is also important. And that also takes off the pressure from the wound as well. Then we have walking aids. They can use crutches, walker. They have the roller scooter now, wheelchairs. All of these things can also be used. The surgical shoe, like this one here. And then this is called a Pegasus. This is a insole that you put in the surgical shoe that you can actually plug the little pegs off so that under where the wound is, there's no pressure. So that is also very effective, and it's easily available here at the medical supply company, so you can get it. If you have access to felt, you can use felt. You can use it. Research has shown that felt decreases the pressure at the wound site by 61%. And so that's a simple and cheap method that you can use to offload that area. This is an example of how you can use it. These are other examples. So this is a person that has an ulcer under the first metatarsal head. And so this is how we put the felt on there to help to heal that. This one here, Dr. Bell showed us how to do this a couple of years ago. And this person here with that ulcer in the middle of the arch, you can also use felt to offload that as well. So you can definitely have, if you have access to it, you can use that to offload that area. Some more advanced offloading techniques are you can use an extra depth diabetic shoe. This, of course, one after the wound is healed. And plastizo insole, that is that peach insole here for the diabetics. You can use the darker wedge shoe, which is a half shoe. I personally don't like this one too much because I find a lot of diabetics are not stable on their feet. And so, especially for older persons, so I tend not to use this one a lot. Custom molded shoes are also like this crow boot here can be used. And then this is something new kid on the block, the foot defender. It's awesome. I would love us to get this here. So we can definitely use that during the healing time. And then of course the gold standard is total contact cast. And then as a podiatrist, a big part of my practice is doing surgery to offload these conditions, because sometimes you have a person who have a hammer toe or a bunion or some other bony deformity, and no matter how you offload that or pad that or do whatever you do to it, they are going to continue to have an ulcer in that area. And so sometimes we need to go in and then just either shave down the bone or take the bone out to be able to have permanent solution to that problem. So here are 5 things that have been proven, 5 P's for prevention for persons who have diabetes and to protect their feet. Podiatry care, protective shoes, pressure reduction that we just talked about, prophylactic surgery or surgery to relieve those bony prominences, and then of course, patient education. Someone has a question?
Kind of on the bottom by one.
Thank you. Okay, so we have talked about the 4 types of wounds, lower extremity wounds. We looked at pressure ulcers, we looked at venous ulcers, arterial ulcers, and of course, diabetic foot ulcers. We know that the most important thing is once you do your assessment, we're going to cover that next week. So once you do your assessment and you determine what type of wound it is, then now you will put those principles that we talked about. For example, for venous ulcer is going to be what? You can open your mic and tell me what type of treatment is going to be for venous ulcer. What type of treatment? Compression, okay. If it's a pressure ulcer, what are we going to do? What do you have to do so that pressure ulcer can heal?
Relieve pressure on the site.
Awesome. So what about arterial ulcers? What are you going to do for those?
Vascular studies.
Awesome. And what else? Referrals to vascular. Okay, awesome. And then for diabetic ulcers, what is the principle for treating them? Similar to the, not say that. So what are you going to do for diabetic ulcers? Okay, it's called offloading. So we're gonna take the pressure off of the diabetic ulcer. So offloading, or you say pressure relief is fine as well, but offloading is critically important. No matter what you put on that wound. Sorry? No matter what you put on that wound, if the pressure is not removed, it doesn't matter, that wound is not going to heal. So we need to take the pressure off. So offloading is the gold standard for diabetic foot ulcers. And we talked about several methods of doing that. Okay, so generally, regardless of the type of wound a person has, there are some basic wound healing principles that we must apply. One is moist wound healing. We know from our parents and older persons, we have always been told to take the bandage off and let the wound air or let it dry, let it be open to the air. But research has shown over and over and over that covered wounds, or wounds that are covered, heal twice as fast as those who are left open. So it's more important to allow the wound to be warm for the cells that are needed, fibroblasts and other wound healing cells. They need to be able to move and do their work. And they do that better in a moist environment rather than a dry environment, because they have to go under the dryness and then go and do their work. And so it's better to cover that wound. And so if your patients are telling you that, or sometimes, you have to ask them, if you see that the wound is stalling, or if you see that it looks dry, you have to really, really just ask them if they leave it open. And sometimes they do. So you gotta, and then explain to them that it's better that it stays covered. Identify and treat any infections early. If there's an infection, that is definitely going to slow down healing, and it will definitely impede the progress that you're making with all your efforts. So infections must be treated early and with the appropriate treatment. So if it's a simple infection, maybe locally right at the site, and maybe you can use something topical. You may be able to use something oral. And then, of course, if it's a raging infection like this this foot hair, then we probably need to refer them to the hospital and have IV antibiotics. So regular wound debridement is another principle where it can be sharp, autolytic, enzymatic. Regardless of the type, you can use a 15 blades, you can use tissue nippers, you can use curettes. So whatever type of debridement is, it relieves the pressure in that area. It stimulates healing as well. And so we need to constantly debride that wound to stimulate it to heal and clean it up, so that we can take away the biofilm and the non-viable tissue so that we're able to heal that wound. Okay, I have 5 minutes. So these are some examples of wounds that had to be treated with antibiotics and other methods so that we can see the progress as well. So the next principle is monitoring wound healing. 53% reduction in the ulcer area in 4 weeks actually predicts healing in 12 weeks. So if that wound, if we don't see any, we're providing good standard of care, wound care, and we don't see any signs of healing, then a lot of times we know that wound is going to be stalled or delayed. We can control pain, of course, persons who are in pain, that affects healing as well, and the person's coping with the wound. And then we select the dressings to manage the moisture as well, so that you don't have to change the wound as frequent, maybe not every day or every other day, maybe a couple of times a week. And then, of course, with a Pro4 or something like that, you can do it once a week. So it's good to select the dressing or what you're putting on the wound so that it assists you with that as well. Consider the nutritional status of the patient, because you're not only treating the hole in the patient, you're treating the whole patient. So we got to make sure that that person is healthy enough and able to heal. And then if not, then we can recommend supplements that the person can take. There are a lot of drinks and collagen and a lot of things on the market that persons can't take. Referral early, like we talked about venous ulcers, patients should be referred as early as possible. In my practice, I sometimes see patients and refer them that very day, because at the end of the day, if they don't have blood flow, nothing I do is going to make a difference, and certainly nothing that you do in terms of dressing it is going to make a difference if they do not have good blood flow. My last comment is that wound healing is a complex process and it is best managed as a team. So don't think that you have to do this all by yourself and all of this has to fall on you. We work together so that we can have the best outcome for our patient. I think I'm out of time, so I'm going to leave those 2 minutes for questions. But at the end of the day, we have a summary here for the different types of wounds, and we have the factors that contribute to them, the anatomic location, the characteristics, the patient's assessments at the time, and then also what are the treatment options as well. So this patient of mine, I inherited her, and our goal is to preserve the rest of her feet for life. And so when I see a patient like her or any other patient, I think of what I can do to make sure that they save their feet, and sometimes it's the rest of their feet for life. And a big part of that is education. And you will learn over the next 4 weeks that as we learn about wound healing this month, that we will put some things in place that can help you to better care for your patients and to prevent amputations like this, and then to encourage wound healing. Thank you so much. Here is my contact information. I can't see that one. So these are my phone numbers. This is our website. So we will also put the recording for this today on our Zoom chart, so you can for persons who may wanted to come and were not able to come, so that they can also watch it. So thank you so much. And I am done. If you have any questions, or if there are any questions in the chat, I will be happy to answer them now.
Okay, so I'm gonna allow for you to open up your mic one by one to ask questions. If you do not want to ask a question directly, you can type it in a direct message to me, and I will ask the question over.
While you're thinking
Hi.
of your question, go
Hi,
ahead.
Dr. Mitchell.
Yes, ma'am.
Yes, you said that if there's no blood flow, there's no need for do the dressing.
No, I did not say that.
No?
I said do not put any cream or
Cream?
no Silvadene, no betadine. The best thing to do, if there's no flow, is put a wet to dry betadine, wet to dry. That means you take the gauze and you soak it in betadine and you wrap it around the wound, and then you dress it as normal, and you send that person to, I guess, Dr. Farquharson or whoever you're going to send that person to. You can also use alcohol wet to dry, but do not put any creams on it. That's what I said. No
Okay.
betadine, no but they be Bactroban, no Silvadene, no something else, bacitracin, anything like that. Just put the betadine or alcohol wet to dry on it, and then you send them to vascular. Let vascular evaluate them, because if you debride the wound or if you make it wet, then that's where they may end up getting wet gangrene. Whereas the wound is dry, it's less likely that it's going to get infected.
Okay, so you say betadine. That's the same betadine they're saying that do not put on open wounds because it destroys the skin or the tissues or
Yes, the
something?
same one. The reason why you're using it on a ischemic ulcer is to keep it dry, and it's not likely that that is going to heal. You would not put the betadine on a granular wound. That's correct, because it is cytotoxic to new cells. So you would not put that on a granular wound, but a ischemic wound like gangrene, you want to keep gangrene dry. You don't want gangrene to get wet. Okay, so if the person has no blood flow, they have a wound that is dry, beginning to turn black, it's looking like gangrene, just put the betadine wet to dry on it or the alcohol wet to dry and send them off to vascular.
Okay, thanks for that information.
No problem. So I think one of the objectives for this session was to make sure our persons have an understanding or an appreciation for the different types of wounds, what causes them, where they're located, and then of course, what are the principles for treating them. And so I hope that we were able to cover that and that you have a clearer understanding about that, because not all wounds, you don't treat all wounds the same. So if you have a arterial ulcer, definitely you would not put them in compression, because that would be counterproductive. The blood flow that they do have, if you compress them, then you're going to stop that blood from getting to the foot. So that is why we wanted to start with covering the different types of wounds, and then also looking at the principles for treating them. And so as we go through the next 3 weeks, we'll be covering a little bit more. So every week you will get more, and you'll be able to put it all together. And then we will send you the PowerPoints so that you are able to have them as resources so that you can refer them. And then my phone number, actually, I forgot to put it up there, was 802-3668. So if you need to get in touch with me, you can always just WhatsApp me, or you can actually just send me a picture if you want me to take a look at it. That's 802-802-3668. You can actually just use that. Okay, so somebody asked in the chat, how does local remedies like green papaya help with the healing process? We actually have our 4th session on that very topic, so I will not answer that question today. We have an expert who will be covering that. I think it's the 27th. Yes, the 27th of June. So come back and we'll be able to answer that question for you. So thank you for the presentation. Looking forward to the PowerPoints. Awesome presentation. Yes, we are recording, and we will make the recording available to persons. Okay, so I don't see any more questions in the chat. Do we have any more questions? If not, then I think we can end, because we want to try to maintain the hour. I'm sorry, we were a little bit, we started at 2:05. So, 1:05, so we're going to end at 2:05. So thank you so much for coming. And nurse, you can close us out if there are no more questions. And then so we can try and stick to our time. We want to stick on time as far as possible. Thank you all for coming. If you need to get in touch with me again, my phone number is 802-3668. So you can just send me a WhatsApp, or if you have pictures or something like that you want to share of wounds or anything like that, you can just go ahead and send them to that number. I'll type it in the chat as well. We are working on the CMEs. They have been submitted to the Nursing Council. So we will, as soon as we get that answer, but we're keeping, you know what? You can type your names in the chat for us, please, or persons, I don't know if you registered, but persons, you should have registered on the flyer that came around. There's a registration QR code on the flyer. So once you hit that QR code with your phone, you take a picture of it with your phone, you will be registered for this session. And then automatically you will get your CMEs, and automatically you will get your handouts, because we're going to send it to that list. So if you did not register, please put your email in the chat, and then we will get it to you. But those persons who registered, you do not have to write your email in the chat. So if you didn't register, write your email in the chat so that we'll be able to record that you were here and that you can get your CMEs. Okay, so the flyer will be coming around again next week for the 2nd session. So make sure that you go to you scan the QR code and register. That makes it easier for us to be able to do your CME. So go to the QR code and it will register you for the session, and then we'll go by that as the attendance. So, because I see everybody typing their email in. Okay, once you finish typing, then I think we can end. Nurse Dean, you can close us out when you're ready, please. Once they're finished. Thank you so much, everyone, for coming. Thank you, Dr. Bell.
So we want to thank Dr. Mitchell for sharing her words, making sure that we recognize wounds by how they look and the things that we need to do for them. Like she said, we welcome you back to next week's presentation. It'll be a 4-week series. So stay tuned for those that will come up, and make sure that you register so that you can be counted for your CNE hours. Thank you again for coming. Have a good day.
Thank you, everyone. Awesome. Thank you, Nurse Dean. Awesome job. I forgot to ask if this was a good time or we should go to 2, but I think it was a good time. Thank you, Ms. White. Thank you. Thank you, Nurse Shepherd. All right, I think everybody registered. I mean, put their email in now. So I'm going to close the chat.